purposes. So, good evening, everybody. Welcome to this another session of Echocardiogram. We have with us Dr. Sanjay Mittal, the ACE cardiologist based at Medanta Medicity at Gurgaon. Previously, he was at Fortis Assurance, moving on to Apollo and finally settling down at Medanta for last almost 14 years now, as far as I remember correctly. He is looking after heart failure programs and an ACE echocardiologist because, as you know, heart failure requires lot of evaluation of systolic, diastolic function, RV systolic function, RV diastolic functions, and PA pressure. And this is one of his favorite topic, which has been delivering for last 21 years. Consequently, it used to happen every Tuesday of the training program, and for the first time, possibly it's happening on Sunday. And he used to curse me, why Tuesday every time? And possibly that curse has proved true today. No more a Tuesday when he used to on fast on that particular day, traveling all the way from Gurgaon to take this class and just used to have a cup. Well, a lot of good food was present for him, which he cannot eat because of his fast. That was his dedication. And I'm always thankful from a core of heart for his all contribution to these programs. With these few words, I hand over mic to none other than Dr. Sanjay Mittal, ACE friend, ACE cardiologist, and on par the best human being I ever encountered in my life. It's all yours, Sanjay.
Thanks, Rakesh. I think you need to be very clear because people would understand you speak the same introduction language for every speaker. Every speaker who comes on this platform will talk the same way. But thanks for the kind words. You are a very nice fellow yourself and a very good friend. Um, what I'm going to talk today is left ventricular systolic function evaluation, and I'm going to focus, as topic says, is the concept of wall motion normalities, evaluation of global systolic function, and a word about TDI and strain. And as Dr. Rakesh was mentioning, that I have been looking after the heart failure unit, and for me, echocardiography is just like a stethoscope. I do it almost on all people to look at their systolic function recovery or otherwise, or to look at the diastolic function, which determines the load situation on the myocardium and left ventricular system. So, what I'm going to talk today is is first mm, regional left ventricular systolic function. So we all know the left ventricle is uh, the pumping chamber of the myocardium, which pumps the blood into the whole system until it is a congenital defect. And this is a cartoon. We know the myocardium itself receives supplies through these coronary arteries. In this case, the left anterior descending and circumflex, the right I'm not showing here. But suppose there is a blockage which has developed in the left anterior descending artery. The area which is supplied by that artery receives less blood and there's an ischemia which sets in. We call this ischemic cascade. This is old and gold that there is a flow heterogeneity which begins, but which leads to some metabolic alterations in the myocardium. Then this leads to diastolic dysfunction. This area becomes rigid and it fails to relax. But most importantly, there is a dysynchrony. That means this area, which is supplied by that blocked artery, reduces its function of systole or contraction. And this is in a place of the rest of the myocardium, which is contracting well. So this is something the echocardiography can pick up. Unfortunately, the diastolic function is too non-specific, and that is why the gold standard is systolic dysfunction, which is located in that particular region. This region, you can see clean. Left ventricle, you can see the basal segments towards the mitral valve are contracting reasonably well. But if you look at the apex, it's hardly contracting, rather, it's going out in systole. So this is a particular portion of the myocardium which is akinetic or dyskinetic or not contracting, whereas the rest of the myocardium is contracting well. And this we call as segmental or regional wall motion abnormality. For all practical purposes, whenever we find a situation like this, that there are certain reasons which are not contracting well, the first diagnosis which comes to mind is occlusion in one of the other's coronary arteries. So this is hallmark of ischemia, and it is diagnostic of coronary artery disease until and unless proved otherwise. There are situations such as palsy myocarditis or certain kind of autoimmune disorders, sarcoidosis, and other things where some portion of the myocardium could be involved, but then those portions do not follow the rule of a coronary artery distribution or coronary artery supply distribution in territories, which I am going to discuss in my next slide. So this is very clear. So to ease out, what we have is we have various scoring systems. There had been 16 segment division of the left ventricle, 17 segment division of the left ventricle, and 18 segment division of the left ventricle. Mind it, everything is the apical segment. If the length of the left ventricle is divided into three equal parts, and I'll describe it down the line. The most commonly practically we use in echocardiogram is the 16 segment scoring system, whereas each segment is almost equal amount of muscle, and apex has four segments. The rest of the levels have six segments each. This is what we conventionally use on echocardiogram, and I would focus on this particular method. The 17th segment, where the central apical portion, tip of the apex, is the 17th segment, and this is usually used for the perfusion studies like we use in thallium. And these are used for spectral tracking or even the MRI when the apex also is divided into six segments. So that is what makes it 18 segments. I'm going to focus on this because this is what the most practical solution is, and I'll describe to you guys in a few minutes from now. So, for the ease of description, we have to now understand that it's not only that some segments or some region of the myocardium is not contracting as well as the rest of the myocardium is, but we also have to learn how to correlate those segments. May I request everybody to just mute their own mics till the time the lecture is going on, and then once the question answer is there, we can start the mics. Otherwise, get disturbances and all. So, say for example, this is a short axis view we all know, and if we look at the parasternal long axis view, what happens is that parasternal long axis view means the beam is cutting the ventricle in this particular axis. So there would be a right ventricular free wall here. There would be anterior septum. This would be here. So this part of the septum, which we look at the difference between the right ventricle and the left ventricle, is anterior portion. You can see here we have the posterior wall. This is the posterior wall. So in parasternal long axis view, we look at the portion of the ventricle would be the anterior septum, not the septum, anterior septum and the posterior wall. On the other hand, if we go to the apex and put our transducer across the apex, look towards the base, we look at the four chamber view. And the four chamber view would have the right ventricle here. This is the right ventricle you can see on the screen. This would be the septum because it is a little posterior part of the septum, but we call it just the septum. We don't call it posterior septum, it's just the septum. So this would be the septum, and this would be the lateral wall here. Mind it, you can see the bulge of this papillary muscle, which is anterolateral papillary muscle, and you can see the papillary muscle head arising from the lateral wall in the four chamber view. The third view, which is also a bread butter view, is the apical two chamber view. We rotate the transducer by about 60 degrees, and we find that the right ventricle vanishes from the screen. So there is no right ventricle. And we just see the inferior wall here, which also is giving rise to the papillary muscle, just like in the bulge here. So it's not the posterior wall. Rising the papillary muscle should be inferior wall. and the anterior wall, which is the front of the vessel. And here you can also sometimes see the left atrial appendage. So these are three different views which we use in the long axis, parasternal long axis, showing the posterior and the anterior septum, the four-chamber view showing the septum and the lateral wall, the two-chamber view showing the inferior and the anterior wall. Now, what happens is that if you look at these particular segments, so this is the representative of four-chamber view, this is the representative of two-chamber view, and this is the long axis view. As I said, the whole length of the left ventricle is divided into three equal parts: the apical, mid, and basal. So there would be basal, mid, and apical septum, apical, mid, and basal lateral, basal, mid, apical inferior, and basal, mid, and apical anterior wall. However, if you very clearly see here, the apex is not visible in the parasternal long axis view. We just have basal and mid segment in the anterior septum region, and basal and mid posterior wall. So we do not have apical posterior or apical anterior septum. This is easy way to remember. But then, as I was mentioning, these segments are easy. We'll have 16 segments: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So these are the 16 segments. But now is the intricacy to try to understand how is it correlating with the arterial territories. We have three major arteries: left anterior descending artery, we have circumflex, we have right coronary artery with variable distribution. I'm going to go with the common distribution, and then you can extrapolate a little bit overlaps, which can happen time to time. So where does the LED run? Obviously, the rule of the thumb is wherever the course of the vessel is, the adjacent segments are supplied by that artery. So for example, LED runs in the anterior interventricular groove in this particular portion, like this, and from base to the apex, and it winds around the apex. So it would be supplying areas of the myocardium adjacent to this supply territory. It would supply anterior septum and anterior wall. It would supply all the way around the apex, so all apical segments, that is apical septum or apical lateral wall also. The complete segments of the anterior wall, basal, mid, and apical anterior and apical inferior, and mid anterior septum. So it supplies 1, 2, 3, 4, 5, 6, 7, and 8 out of 16. That means almost 50 to 55% of the myocardium is usually supplied by the LED. Until is very short, which happens in 5% of cases. But when it is short, it supplies less amount of myocardium. The other rule is the course of the LED is from base to the apex. So if the arteries involved at the apex, only apical segments are involved. However, if the artery is involved at the base, apex is involved, but basal segments also would be involved. So if they are wall motion abnormalities only limited to apex, this is usually mid or distal LED. However, if the mid segments and basal segments are also involved, you can also predict that this LED is proximally involved, and it's a larger area of myocardium which is at risk. Let's talk about the circumflex. From the anterior portion, it goes and winds around in AV groove and goes back to the posterior interventricular sulcus. And this way, it gives OMs which arise again from the base and go towards the apex, right? So it would supply the lateral wall and the posterior wall. The mid and basal lateral, and mid and basal posterior wall is supplied by the circumflex. Again, it's not a rocket science. If there is a proximal circumflex disease, the proximal OMs would also be involved, which would mean the lateral wall is also going to be involved. If the circumflex is involved distally, that means only the posterior segments would be involved and the lateral may be spared. So that is why a common circumflex, which is a usual size, if it is involved proximally, lateral and posterior both would be involved. If it is involved only distally, maybe the only posterior segment will be involved. So that is how we can only not recognize circumflex, but also whether it is proximal or distal. Let's talk about the inferior wall, because posterior descending artery, whether it is coming from the circumflex or from the right coronary artery, and then it goes and supplies the PLBs, posterior left ventricular branches. Then it would be supplying, the PDA would be supplying septum, basal, and mid septum, and the PLBs would be supplying basal and mid inferior wall. So these are the four segments supplied by the RCA, right coronary artery, commonly, and there would be an overlap depending upon which artery is dominant. So commonly, usually what would happen is that if we look at the arterial distribution, four segments of RCA, four segments of circumflex, and the LED 1, 2, 3, 4, 8 segments of the LED. In the four chamber view, you have representations of all three arteries: the apex by the LED, the septum by the RCA, usually, and the lateral wall by the proximal circumflex, usually. So, this is what is the representation. Now, at times, what we can do is we can have four segments at the apex. This is the papillary muscle level, that is the mid segments, and the basal at the level of mitral valve. If we look at six segments plus six segments and plus four segments, we can have a bullseye plot drawn by these things, like this particular thing. And if you look at the LED, it runs through the AV group from anterior portion winding around the apex. So all these eight segments supplied by the LED: basal, anterior, basal anterior septum, mid anterior septum, and all the four segments at the apex are supplied by the LED. On the other hand, the circumflex runs in the AV groove, giving rise to OMs which go from the base to the apex, and they supplied the lateral wall and the posterior wall. PDA is supplying the basal and mid septum, and PLB is supplying inferior and mid and basal inferior wall. So this is the usual distribution of common occurring coronary artery distribution. Now, other word is about quantification. Once we have a qualitative data of wall motion abnormalities, it is important to translate that into medical form so that we can use that into equations and for analysis. So these are certain terms which you use: normal. Normal is when the systolic thickening, the difference between diastolic and systolic thickening of that particular segment is more than 50%. That is, if it was 1 centimeter in diastole, it becomes 1.5 centimeter in systole, then it is normal. Hypokinesia is when it becomes 20% to 50%. That means from 1 centimeter, it becomes 1.2 to 1.5, less than 1.5. It is hypokinesia. Akinesia is less than 1.2. Dyskinesia is when there is actually thinning during systole. And aneurysm scar is when there is outpouching into diastole as well. That means it has lost all contractile muscle and it's all scar. This aneurysm is never going to recover. It's all scar until unless somebody operates upon and removes the scar. This is going to remain. Even dyskinesia, as we move from normal to aneurysm, we lose the contractile or possible surviving muscle. And that is why the value given to these is a score of reverse order. A normal would be 1 and 5 would be aneurysm scar. So if we have a higher number, this means that myocardium is gone. And higher the number is not good to have. Now, practically, we have discussed about the terms, but practically the importance is to understand how do you translate that into your day-to-day clinical practice. Normal is what our eyes have been tuned to look at a normal contractility. And sometimes what happens is when there is a wall motion abnormalities, the most contractile segments is ranked as normal, especially when there is a wall motion abnormalities types. Hypokinesia is a situation where even if we don't calculate the thickness change, you look at contractility, you'll say this segment is contracting. That means you can see the change in thickness, but it is not normal. Then that segment is hypokinesia. Akinetic is that the person's that particular segment is not seen to change at all, because our visual perception, our eyes cannot see perceive less than 10% difference in the thickness. So any segment which is not seen to change any thickness is akinetic. And dyskinesis is when you see outpouching during systole. That is dyskinetic. Aneurysm is when the dyskinesia or change in shape is persistent in diastole as well. So let me show you a few things after this particular slide, that once we have a wall motion abnormality, a good echocardiographer should not only just be able to diagnose the presence or absence of wall motion abnormality, it should be a severity. That means either it is hypo, akinesia, or dyskinesia. Whether there is scarring, and scarring is detected by change in the quality of muscle, the echo refringence of that particular segment, which vesicular territory is involved. And it would be wonderful if you can see whether one vessel is involved or multiple vessels are involved, because this is a prognostic marker. And this is possible. You have to train your eyes. It is definitely very much possible. I give you an example. This is a parasternal long axis view, right? You look at this particular segment. What is this segment? Is it septum? No, it is anterior septum. The basal anterior septum is contracting extremely well. Mid anterior septum is contracting well. But if you look at the posterior wall, the endocardium is not visualized here. It's here. So this particular segment is dyskinetic. It's moving out. It's thinning out in systole. So this particular person has a dyskinetic mid and basal posterior wall. But normal LAD segments here, even the apex seems to be contracting pretty well. So what artery territory possibly is going to involve? I can say LAD is fine, but I would say that probably the person has sustained a circumflex territory infarct. I cannot predict on the single view whether it is proximal or distal. So this is another patient. What is happening? This is four-chamber view and a two-chamber view. You can see the basal septum is contracting well, mid septum is contracting well, apical septum is contracting well. So basal septum and mid septum, right coronary or PDA territory. That means right coronary should be fine. The apical contraction seems to be fine too. And the lateral wall, the basal lateral and mid lateral is akinetic. Apex is contracting decently well. Here also, this is a two-chamber view. The right coronary artery territory, basal inferior, mid inferior is contracting well. Apical inferior is also contracting well. The LAD territory, the mid and basal anterior is hypokinetic, and apex also seems to be hypokinetic. So if we cut short the whole scenario, the basal posterior was infarcted, the lateral wall is infarcted. So definitely this is a circumflex territory infarct, which is proximal. And there should also be some involvement of the LAD, which is not infarcted, but it is hypokinetic. So that means a substantial muscle here is alive, however, hypokinetic. So this is a double vessel disease, which I'm talking about. This is another patient. You can see the paradox here. This is posterior wall, basal, and mid posterior wall is contracting extremely well. But look at the LAD territory. The basal anterior septum is hypocontractile, mid anterior septum is not contracting, and apex obviously is gone. So whenever there is a wall motion abnormality involving the basal anterior septum and mid anterior septum, this has to be an LAD, and the LAD involvement is proximal. So this is a proximal LAD lesion, which I'm talking about. So there are other confusions about the wall motion abnormalities, because it is a three-dimensional organ which is contracting in three dimensions. It is not only pumping like this, it is contracting, writhing around. So this motion is not easily to be captured in a two-dimensional image, and we have to be cautious about that. I give you an example. So this is a posterior wall. It is hypocontractile. Basal anterior septum is fine, normal, and mid anterior septum is a confusing area. If you look at it, you'll say it is hypocontractile. But then if you focus on the change in thickness only on this segment, you will come to know that this is hardly perceptible change. And this is what we call as a pull effect. That means because of the hypercontractile basal anterior septum, it is pulling with itself inwards the mid anterior septum, which may then be ranked as hypocontractile. We call this a paradox, and it's a problem, a very common problem if we do not focus on the thickening. We just look at the movement, because movement can be passive. The thickening cannot be passive. It is an active contractility. And this can be because of pull effect, as I shown here. Sometimes when the heart rate is very high or there's a passive movement in the chest, these kind of confusions can happen. We have to be very watchful. On the other hand, this is a particular very common case. You look at the septum seems to be hypocontractile because the contractility seems to be less. But if you look at the change in thickness, it is contracting pretty decently well. So this is a normal contractility. The only problem is there is a difference in phase. Septum seems to be contracting before the lateral wall, and that is why we are having a paradox. So this is again, we have to be focusing on thickening. Here, the movement is restricted, but thickening is maintained. So this is normokinesia, but this thing is very commonly found in left bundle branch block, WPW, and also in right ventricular pacing, where the septum is stimulated before the lateral wall. So the majority of myocardium is contracting in a particular phase. The septum has by that time contracted already. So this thing is also a common reason for fallacies. I showed these four pictures here. Let's focus on this. This is anterior septum, basal anterior septum, mid anterior septum in a parasternal long axis view, right? This segment is basal posterior, and many of us would rank this as mid posterior, right? Same way, this would be basal and lateral, mid-lateral, papillary muscle is seen here in the four-chamber view, apical lateral, apical septum, mid-septum, and basal septum. But there is where the error is. You have to look at the landmarks. We did discuss that the papillary muscle does not originate from the posterior segment. It originates from the inferior wall. And very commonly, when we are doing an echocardiogram in systole, sometimes throughout the cardiac cycle, we look at the origin of papillary muscle, where this is inferior wall, not the posterior wall. On the other hand, this is the aorta which is opening. So we are almost like five-chamber view. And when we are opening the aorta, which is anterior, this segment becomes anterior septum rather than the basal septum. So we have to look at the landmarks, especially throughout the cardiac cycle. Until as we do that, we'll make consecutive errors. And that is something which we have to be very watchful about. So improper views lead to improper definitions. The other thing is that if you look at the two-chamber view, sometimes the long axis view is not good. Then in such situations, we have to do the wall motion analysis, the basal segments at the mitral valve level, the mid segments at the papillary muscle level, and the apical segments, four segments at the apical level beyond the papillary muscle level, and look at the segmental contractility in this short axis view. And we can confirm the wall motion normalities in the long axis view. Another example, the basal septum in the four-chamber view, this is four-chamber view, is fine. Mid-septum is fine. Apical septum is hypokinetic, right? The apical lateral is fine. Mid-lateral is fine. And basal lateral is fine. If you look at this, there seems to be hypokinase just of the apical septum. Ejection fraction, if I estimate here, it should be almost 40-45%, even more than that. And that is what my estimate is. Let's look at another example. This is the basal septum, which is fine. Mid septum is akinetic. Apical septum is akinetic and thinned out, scarred. The lateral wall, apical lateral is akinetic, scarred. Basal lateral and mid lateral are hypokinetic, right? So in contrast to this particular example, this is definitely a poorer ventricle. The ejection fraction here would be about 25 is 20 25 is exactly right. Can you imagine that both these patients, both these echocardiograms are of the same patients, and they're just a few beats, few seconds apart, which were taken. This is a foreshortened four-chamber view where you can grossly miss the apex contractility, and the apex is not visualized here. And that is why you can make ejection fraction from 20 straight away to 45% without doing any intervention. And that is something which we have to keep away. One of the ways to look at it and confirm is we are looking at the tip here. So in this particular segment, the tip of the transducer is here and cutting the ventricle like this. The apex, which is out of the transducer focus, is something which is a very common error. And this happens because we are a habit of starting the transducer from the parietal long axis view, and then we go to the apex. And as soon as we look at the apex, we halt there. This is a big problem because if we halt there, we would only have a situation like this. We should keep on going out and down till we lose the heart, and then we start looking the heart back. That is when we'll have a good image like this. Otherwise, we'll do the error, and this is called the error of foreshortening. We have to be very cautious about. Another example, this is the parietal long axis view. The posterior wall is fine. And the anterior wall, this is scarring, and it seems to be hypokinetic, akinetic. If you look at the four-chamber view, again, the basal septum and mid-septum is fine. Apex seems to be hypokinetic. Mind it, up to 5% of cases would have difficult windows because of obesity, because of the lung interfacing. And whenever we have such kind of a situation, we should have courage to say that the images are not visualized. Until unless we look at the endocardium, we should not comment upon the contractility because the myocardium is not well visualized. And I think the best part of us would be to be able to claim that we are not able to visualize a particular segment and we cannot report on the ventricular function rather than report it wrongly. Somebody else can do by some other method, maybe MRI or maybe a transesophageal echocardiogram and or contrast echocardiogram and get better information. One more thing before I go to the left ventricular global functions, that in acute coronary syndrome, there is ischemic pain, there is elevated biomarkers, and there is ECG changes. There is no mention of echocardiogram. And the reason for that is echocardiogram, unfortunately, cannot distinguish between dead or alive tissue on a short term basis. The only way it can predict that this area is dead is by presence of scarring. And in acute term, when the acute coronary syndrome presents, it cannot differentiate the myocardial infarction versus ischemia because the scarring would take time to develop in weeks to months. And that is something which is the lacunae of echocardiogram. We should not diagnose infarction on the acute coronary syndrome settings in acute emergencies. A word about left ventricular global systolic functions. The M mode and the two plane is given up. We should not use that. And I'm going to end the discussion on M modes here. It is a single dimension study. And in M mode, the axis would be like this. It would be crossing the ventricle obliquely, overestimating the left ventricular size. And if the left ventricular size is overestimated, volumes are overestimated, and this would be giving a grossly overestimated end-diastolic and end-systolic volume and a problem. So please don't indulge into M mode and calculated indices for left ventricular size or ejection fraction. The best method is Simpson's method, and we use in practical terms modified Simpson's method. Simpson is the whole length of the left ventricle is divided into 20 discs, and what it does is it calculates each disc's surface area and volume by multiplying the height of calculated disc disc about a centimeter, whatever the disc thickness would be, dividing with 20, and the radius of that particular segment, giving rise to a summation of 20 discs to lead to a volume calculating the whole of the ventricle. And this is again a simple formula: diastolic volume minus systolic volume divided by the diastolic volume gives you an ejection fraction. So that is the common area, whether you like it or you don't like it, ejection fraction has to be calculated and reported every time and then. So we have a diastolic view and a systolic view. The whole length, what we do is we trace the endocardium in diastole and in systole, and also the machine then asks for the length from the apex to the base segment, mid segment. Then it divides everything into 20 sectors and calculates the volume of each disc and summates. So end diastolic volume and end systolic volume. The same modified Simpson's method would be applied in two chamber view, and then both the chamber views should be averaged out to give you an ejection fraction. That is the best way out. But we have to look at a few things. ECG is not always accurate because the QRS, which part of the QRS you're focusing on is a problem. So we look at end diastole and end systole according to the frames. The frame with largest ventricular cavity size is the end diastole, and I would say that it is just before the mitral valve quacks. At that particular point of time, this is end diastole. And systole is when the mitral valve has contracted, smallest LV cavity size, and it is just about to open. And that is when we have to look at the end systole. So this is how we time the end diastole and end systole dimensions to calculate the volumes. Mind it, the best one still today is your experience-driven eyeballing. When you look at the ventricle, this should be around 40%, 40 to 45%. That is what your gold standard is, because time and again it has been proven that the maximum R value was with the wall motion score of eyeballing. Three-dimension echocardiogram is something which can give you a better outcomes, but because of the fact that there is no geometrical assumption here, and it is unaffected by the foreshortening, as I described in the two-chamber view. But the only problem is that 3D is based on 2D images. So if you have bad image, improper outlining of the endocardium, the improper assessment of ejection fraction also is going to be by 3 dimensions. So that is something which we have to be watching for. Besides, the 3 dimension can also give us the segmental contractilities, and every segment can be plotted, the diastole and the systolic volumes, and the segmental ejection fractions can also be calculated. A word about tissue Doppler. So the difference between tissue Doppler and the regular Doppler is the regular Doppler, there's a frequency shift. The higher the frequency of the smaller things, that is blood, the frequency shift is more. And so you have to filter out the noise. That means you filter out the low frequency shift, the noise. On the other hand, if you filter out the high frequency shifts and just look at the low frequencies, changes in the frequencies, you can pick up the tissue movements. Because in the left ventricular cavity, blood is moving, but the walls are also moving. So if you look at the higher frequency shifts, the blood gives a higher frequency shift, and the tissue gives more volume change or distance change, but at a low frequency. So if you filter out the higher frequency, you can just pick up the lower frequency and see whether the contractility of the left ventricle is represented in changing the annulus plane. And that is something which we call as tissue Doppler imaging. And it can be also correlated by color. In this particular patient, there's red, And also you can see the amount of magnitude shift is quoted like this. So this could again give you a practical important dimension of cardiac contractility as well as diastolic function. I have to give you a concept of strain. So if you look at multiplane imaging, the left ventricle is base and apex. So there are a lot of contractilities here. One is there is a contraction, the ventricle becomes shorter, just like this, and it becomes thicker during systole. So the changes are the length shortens. So that means with contraction, ventricular contraction, the length of the left ventricle shortens. So the longitudinal, this is the longitudinal contraction would happen. And on the other hand, the circumference would shorten, but the radius would increase. So the change in systole is shortening of the length, shortening of the circumference, but increase in the radius. So these are the changes which are brought about with the cardiac contractility. So with this thing, what happens is the machines today are intelligent enough not to only notice that, but also the rotation and twists. You can look at, it's not only the change in the diameter, but the whole apex is seems to be contracting and rotating. This is why the ventricle is actually writhing. It's just like writhing. You know, the basal segments go clockwise and the apex counterclockwise, which makes it writhing. जैसे कपड़े निचोड़ रहे हैं ना, इस तरह का एपिसोड होता है. That is what the muscular factors are. And now we can have a rotation twist analysis also based on this. But what is the concept? The concept is coming from speckled training. What happens is each of the part of the myocardium, for example, this is the septum, is denoted by the machine as speckles. There are speckles here. And mind it, all these speckles are just like fingerprints. They are a characteristic of that particular portion or segment. So now what happens is it tracks the change in that speck. Say, for example, it is focused on this particular speck with the time, and it sees the change from this portion here, it comes to here and here. So this change in speckle is the change in length. So if you look at the change in length, you have either shortening or lengthening. Or in the case of radius, it is again shortening or lengthening. So this change in length is what we call as strain. So what happens is if there is a reduction in length, this is a negative strain. And if it is increase in thickness, this is positive strain. So for that matter, as we looked at, and during systole, the length reduces. That means there's a negative strain in the longitudinal axis during systole. The circumference shortens. That means the circumference reduces negative strain in the circumference of the left ventricle in systole. The radius increases in systole. So that means the radial strain increases, or that is a positive value. So what the machine does is it actually calculates the whole segments, the basal segment, mid septum, the blue, the green is the apical septum. The apical lateral is violet, blue is mid lateral, and basal lateral is red. So it continuously calculates the change in the distance between all these segments, and then later on it plots on the graph. So for example, this is the example. So what it does, each segment change, the volume change can be calculated. It goes up and then down and then up. So all the segments are plotted in the change of volumes. And this is something where we can give the strain. So the change in length was minus 28 in this particular segment, which was calculated. Minus 26, that means the systolic length was minus 28 of the diastolic length. Simple as that. Minus 26, minus 24, minus 13, minus 19. And today we also can draw it on a bullseye plot. We can also color code them, so that extreme red means a very good contractility, more than minus 20, more than, rather I'll say less than minus 20, because it is a negative value. So if the negative value increases minus 20 to minus 21, minus 21 is smaller than minus 20. So the value minus 26 is better, more contractility. And the pinker one and lighter pinker one is less contractility. Normal value for GLS, or global longitudinal strain, is about minus 20 in most of the machines today. So in today's world, the global longitudinal strain is advantageous because it is reproducible, because it is eliminating the human error. Normal changes are defined well, and there's progress in GLS. Prognostic value is established specifically in people who have preserved ejection fraction, and we find the GLS to start reducing even before the ejection fraction reduces. So early detection of HFpEF, heart failure with preserved ejection fraction, huge role in oncology services, aortic stenosis, valvular heart diseases, huge role there. The disadvantage is unfortunately vendor dependent, but today there has been an effort to universalize or uniformalize the various systems to give us the uniform readings, and it's still dependent on 2D images. So I say is garbage in, is garbage out. You have to focus on a good image. Circumferential strain, as again I said, circumference reduces, so it is again a negative value. But on the other hand, the radial strain is a positive value because the thickness increases during systole. So I end my talk here with an example. In this particular view, this is a four-chamber view, and you can look at the contractility. Almost all segments are contracting really well. This is a two-chamber view, apex also inclusive, anterior wall and inferior wall contracting extremely well. The long axis view, then parasternal axis view, everything contracting well. So this person was a patient with recurrent angina at rest and at minimum exertion. And he was in the clinic and the ECG was normal. And this is what the echocardiogram is. Can you imagine? We did a longitudinal strain and we found that apex, although seemingly contracting well, the contractility or GLS was lesser in the apex, which means it was the terminal LAD segment. The angiogram, and also you can look at this particular segment, there was a disparity here. The apical segment was not contracting well, and this person was then subjected to an angiogram and was found to have a tight mid LAD lesion, which was subsequently angioplastic. So this is what is important, that sometimes ejection fraction can fox us, the visual assessment of wall motion abnormalities can fox us. So in these situations, the longitudinal strain can come to our help. The recommendations is that strain imaging for CAD, it can help us in detection of ischemia, diagnosis of acute coronary syndrome when the wall motion abnormalities are not visible because of diastolic stunning, transmurality of infarction for prediction of LV remodeling, risk of ventricular arrhythmias. The If the strain is higher, that means the value of strain is minus 18 or more, that is minus 17, minus 16, minus 15. It is a predictor of ventricular arrhythmias, and it is also a predictor of overall prognosis. Overall GLS is an important predictor. So ladies and gentlemen, I'll end my talk here. I hope I could make my points clear. If there are questions, I'm happy to take questions from